Yeah, so today I've been wanting to review respiratory therapy stuff in the ICU, going over a lot of different hypoxic respiratory issues that may encounter. Don't really get that much practice to it on the board questions, so I thought I would just kind of practice here with these questions. All right, hello. Today I wanted to kind of practice more respiratory cases. So I went on the respiratory zone for the TMC practice exam. Kind of curious how I would do on it myself. It is a lot of concepts that we don't necessarily focus on, but I do think if I go through a pass of the material, it'll help me a lot more on the wards in the critical care unit, and it'll help me be a better physician. So going to start the quiz now. All right. 64-year-old female patient, dyspnea, hypotension. Hypotension's bad. Tracheal shift to the right. There's only a couple things that can cause a tracheal shift. Maybe a mass, a pneumothorax that is pushing the trachea over. Could be like SVC syndrome, anything pushing it over. Absent breath sounds. Probably pneumothorax, reduced chest expansion, hyperresonant. So only a couple things can cause hyperresonance too, usually involving air inside the lungs. And it's on the left side, so it's opposite from where the tracheal shift is. Pneumothorax on the left, pushing it to the right, if I had to guess. All right, unilateral, reduced chest expansion is important. Hyperresonance was important. Atelectasis can cause tracheal deviation as well. However, it has to be really bad. 39-year-old male, fever, SpO2, 87%, so desaturation and fever, thinking some kind of infectious process, most likely fever and desaturation, maybe pneumonia, COPD, exacerbation, bronchi is heard, productive cough. So kind of thinking more along the lines of pneumonia and COPD. Would you intubate? Probably not. You can try the less invasive modes first, like nasal cannula, non-rebreather before going to ventilation, non-invasive positive pressure. That could be good. Implement postural drainage. That makes sense too. They have a productive cough. We can probably improve and break up the mucus, provide oxygen therapy, and obtain sputum sample for culture and sensitivity. If we're really going with the pneumonia here, that's most likely what we would do. Uh, that way we can get the ball rolling on what the bug is, and this probably means starting nasal cannula, which we would want to do to try to get the SpO2 back up to 92%. All right, yeah. So neither intubation or non-invasive ventilation should be started, I think. Like probably go start with nasal cannula first, then move on to those more invasive methods. 50-year-old male intubated, size 8 endotracheal tube, volume controlled ventilation. Reflexively, I always think if it's volume controlled, AC ventilation, we want to check pressures, plateau and peak pressures. Patient's cuff pressure is measured at 38 centimeters, right? So cuff pressure, you usually want less than 30. So let's just go through the different choices. Withdrawal the tube 1 to 2 centimeters. That really has nothing to do with the cuff. Recommend reintubation. We already know this is too high, so it's lower the cuff to less than 30. Yeah, the cuff pressure should really be between 20 to 30. They're not giving us any information about what, like, where the endotracheal tube is, so you don't really know if you should withdraw the tube, unless, of course, it's a right main stem bronchi intubation. However, they don't give us any indication that this is it. There's really no indication that you should intubate with a smaller endotracheal tube. They're not really giving you any pressures on the ventilator. They're just giving you the cuff pressure of the tube. And then tracheostomy, they didn't tell us like how many days the patient has been on the ventilator, nor are they telling you the patient's prognosis. If they were to tell us like this patient is terminally ill, going to be on the ventilator for more than 12 to 14 days, then we can consider more a tracheostomy. All right. So question 4, assessment of 52-year-old female getting oxygen nasal cannula, bubble humidifier making whistling noise. So nasal cannula, any type of oxygen, it can be dry, it can damage and irritate the mucosa. That's why you would give some fluid with it too. So you could humidify it, make it more easy to digest or palate for the patient. If it's whistling, that means there's a clog in the tube that's causing this whistling. It's kind of like if the bubbling has to get out somewhere somehow. If it's not getting through to the patient, then it'll back up and then make a whistling sound. So if ever there's a kink in the tubing or um any blockage, if people step on it or if there's someone's pinching it, then the relief valve will make some sounds and then it'll whistle when it exceeds a certain amount of pressure. So then the right answer, yeah, could be obstruction. If they're breathing too quickly, no. Clogged system diffuser, and then the flow meter is too high, so could be clogged or obstruction, but it's like if there's a kinking of the tube, mostly. Pre and post bronchodilator test was ordered. So the reasons you would do that, it's probably asthma. And then you want to see if if it's reversible or not. If it improves by more than like 12 to 15%, then you know it's reversible, right? So increase in FEV1 60 to 80% of the predicted value. That's good. That means it's probably asthma. It's probably reversible. If it's fixed, then you wouldn't see any improvement. This doesn't tell you anything about the diffusion capacity. You would have to do a DLCO, find diffusion capacity of the lungs. You would see decreased diffusion capacities in patients with emphysema or some kind of like proteases or proteolytic things that are destroying the elasticity of the lungs. Restrictive process is more like the vital capacities and not really the expiratory volumes. So, yep. So the obstructive process is relieved as you give a bronchodilator, like methacholine, increases the forced expiratory volume greater than 12 to 15%, 20% is very, very good. Breathing asynchronously, breath sounds absent on the left side. All right, are we thinking another pneumothorax again? Are we thinking it's on the left, so maybe a right main stem bronchus intubation, trachea shifted to the left, so on the same side. Maybe it's a left-sided pneumothorax. Instead of tension, it's spontaneous, because spontaneous goes on the same side. Dull percussion, no, on the left side. So that gets rid of our pneumothorax hypothesis, because usually that's hyperresonant. So what's happening here? Tracheoesophageal fistula, maybe tension, pneumothorax has developed on the left side, but that would push the trachea to the right side. Endotracheal tube is in the right main stem. Yep, if it's in the right main stem, it's easier to get in the right main stem because of the anatomy of the airways. The right side is it's shorter to get to the right side. The radius is larger and the angle is more downward, so it's easier to get into it. Diffuse bronchospasm, you wouldn't hear absent left lung sound, right? So just kind of going back over the choices, dull percussion note, tracheal shift. It could mean atelectasis too. Um, it's because those airways are not getting adequately ventilated and perfused. Bronchospasm causes wheezing instead of decreased lung sounds. So you would actually hear a narrowing, like kind of like the whistling that you saw in the bubble humidifier. It's just when it's more narrowed, the air will make a higher pitch sound. Okay, pressure, intubated, pressure controlled AC mode. So you always think when they're getting pressure control, that means there's probably going to be a problem with the volume because when you control for one thing, the other problem is usually the other thing is probably going to be problematic. So this all stems from the fact that compliance equals volume over pressure. So if they're inversely related, so if you're controlling pressure, that means pressure is not going to change. It's going to be a constant. That means volume is going to be the problem. So if the compliance were to decrease, right, pressure controlled, that means the tidal volume will decrease. So right away we can say a peak pressure will increase, but you're setting a pressure. If the compliance goes down, your pressure that you're putting in is the same. I time has nothing to do with the pressure. Peak level will decrease, but you're setting the peak. So understanding compliance is important here, right? It'll be a constant pressure. So everything dealing with the pressure, it's constant. So peak pressure, peak should not be affected, right? And then as a result, your volume will be affected. So actually, I had a case on the floors. That patient is usually most people do volume control, but this patient was pressure controlled mode. And then because they set the pressure, the patient was having a little bit of a leak inside the tracheostomy tube. So even though there was a set pressure, the patient wasn't receiving all of it. It was being leaked out. So you can tell that on the ventilator, there's going to be a certain waveform, and you look at the tidal volume exhaled and inhaled, and there will be a discrepancy. So that's just a general key, a shortcut to look at. If you're controlling for pressure, pay a lot of attention to the volume and you'll catch a lot of problems that way. If you're setting the volume, pay attention to the pressure. And if you notice irregularities in the pressure, then you could catch problems that way too. All right, 70-year-old male intubated receiving mechanical ventilation in volume control mode. So volume control. there might be a problem with pressure here. Um, After performing endotracheal suctioning, which of the following would be effective clearance of retained secretions, right? So indicate effective clearance. So it'll have something to do with pressure. Usually you always look for the opposite. So increased tidal volume, no. I to E time, nope. So you're looking at the two different pressures. So which ones tells you more of a resistance problem? So this would be there's two different types, the peak pressure and the plateau pressure. Elevated peak pressure is greater than 40. You think more of a resistance problem if there's also a difference with the plateau. However, the plateau pressure is greater than 30 and the difference between the peak and the plateau is low, then you can think of it as more of a compliance problem. So peak is more of a resistance problem. Yeah, so it retains secretions. That's why you set these pressure alarms. So then when they go off, you know, like something is wrong within the airway causing resistance or compliance. So resistance is anywhere in the airway from the tube. So if someone's biting on the tube, that can increase the airway. If there's like secretions in the tube, if there's a obstruction, then you'll skyrocket the peak pressure. It goes to the bronchi bronchioles. So if there's bronchospasms too. Like the question before was talking about bronchospasms. If there's bronchospasms, it's going to increase the peak pressure as well. And obviously, if these things increase the peak pressure, when you do a good job of suctioning, when you increase the size of the endotracheal tube, then you'll improve the patient's peak pressure. So mechanical ventilation tachypnea. All right. So patient is over breathing the vent. They're spontaneously breathing, tachypnea. Maybe it'll be asynchronous. Maybe we'll have to do something to slow down the rate of breathing. Notice tracheal deviation to the right and decreased breath sounds on the left, hyperresonance on the left. So looks like the right side tracheal deviation and hyperresonance on the left. So maybe there is a pneumothorax on the left again, because hyperresonance makes us think that there's air in the lungs where there shouldn't be, like air between the visceral lining and then the pleural lining. And then you have tracheal deviation. So going back to the concept before, pneumothorax on the left, and it's tension pneumothorax pushing the trachea to the right because there's this air on the left side that's pushing the trachea to the right. What we want to do is an insertion of the chest tube. That's what you do for pneumothorax. And generally the landmarks are going to be you can do it mid-clavicularly, or you can do mid-axillary, which is like along the armpit. So for the clavicle, you go to the second intercostal, whereas clavicle, second intercostal, axillary go like 4 to 6. See, yep. So basically, um, here it's like this is clearly indicating a tension pneumothorax. You have tracheal deviation away from the affected side, and then the affected side, um, you'll have no breath sounds, and then you'll have hyperresonance. I think that was like the key giveaway here. So 57-year-old female with pulmonary edema. Think pulmonary edema, maybe like CHF, GIF, Lasix, or try BiPAP or CPAP, some non-invasive ventilation strategy to move the lungs away from the fluid, the fluid away from the lungs. So they ordered albuterol treatment via a nebulizer. All right, so what do we do? As I said, like get rid of the fluid in the lungs. Like that's of priority. So you would give something like Lasix and BiPAP. Okay, so that would be D. So maybe some fluid overload. So yeah, when you have respiratory cause of distress, you have to really think about what is driving the respiratory distress. And there's a really good pyramid that I like to use, like this one. So it'll help you know like where is the cause of the respiratory distress. Um, is it coming from the lungs? That's usually going to be the most common problem, right? It's a pneumothorax, COPD, pneumonia, ARDS, pulmonary embolism. Is it from the heart? CHF, tamponade, myocardial infarction, arrhythmia. Is it from like a low blood problem, right? Like less blood, maybe blood is faulty. Maybe there's like carboxyhemoglobin bound to it. Maybe it's an acid-base problem, like a kidney problem too. So you have to think about what is driving the respiratory distress so that you can treat it. If it's coming from the lungs, then yeah. If it's COPD and asthma, then giving the albuterol, as in this case, would help. If it's coming from a pneumothorax, it's not going to help. You're going to want to do that chest tube, as we saw in the previous question. If it's from a heart attack, you want to give oxygen and then start ACS, like do a CAT, start heparin drip, start aspirin Plavix. If it's from CHF, as in this case, then we want to do Lasix and the non-invasive pressure ventilation. If it's from tamponade, then we want to do an echo, see if we need to do a pericardiocentesis, see if we need to do a window, right? So, all right. So figure out the cause of the respiratory distress. In this case, it does seem like it's more cardiogenic, pulmonary edema. So that's why we would give the diuretic. All right, 39-year-old female, emergency department. They couldn't do an IV. All right. So just try again. Get IV team. Get an ultrasound. Try to put an IV. Why are they admitted to the emergency department? Narcotic overdose. They want to give naloxone. So naloxone can be given through the nose. It can be given through the IV, but it also can be given through the endotracheal tube. So let's see. Endotracheal tube. Actually not sure completely all the different ways that naloxone can be administered, but endotracheal tube's going to be the correct answer here. Usually there's intranasal form, there's IV form, and then there's also endotracheal too. So yeah, so different drugs that I remember with endotracheal tube intubation include, and you can use this mnemonic called naval. So naval is used not just for as a mnemonic for the landmarks in the femoral area, um, where if you go, it goes distal to proximal or like lateral to medial. It helps you map out the landmarks of the nerve, artery, vein, and the lymphatic system. That way, when you're like doing surgeries there, or if you're putting a central line, you can find the artery and then move medial because that's where the vein is. The other mnemonic for that is venous penis. However, navel can also be used to remember the drugs that can be put through the endotracheal tube, such as naloxone, atropine, vasopressin, epinephrine, and lidocaine. When you're putting these medications down the ETT tube or any tube or anytime you give medications, even IV too, you have to remember that the tubing takes some of the medication. Some of the medication is bound to the tubing. So a good general rule is like half of your medications are going to be lost to the tubing, and that sounds um really awful, but that's just the general truth of it. So when you're calculating how much insulin that you give to a patient with DKA, just remember half of it's going to be lost in the tubing. So 2 to 2.5 times more of the medication you have to give for it to be effective. So 80 kilogram patient, volume controlled ventilation, FiO2 40%. So again, volume control. So that means it might be a pressure problem. Tidal volume 500. 12, 500, 40. We don't know the PEEP here. ABG is come back. pH good. PCO2 good. HCO3 good. PaO2 a little bit high. Ventilator settings, breathing well on its own, breathing above the ventilator at 23, minute ventilation 11.5, vital capacity 500, good. There's no leak. That's the same as the tidal volume. NIF, -15. All right, yeah, so the NIF's decent. So it looks like he's not, but he's like not ready for spontaneous breathing trial. Um, Tidal volume 500. That's good. So I think at this point he's good. He's good to be kept on these ventilator settings. Perhaps we can try CPAP-A. They're within normal ranges. What would I do here? So there's two results that say like spontaneous breathing trial results. So that's probably not the right answer. Like I'm not completely sure, but just using test taking strategies, if there's two choices that indicate spontaneous breathing trial, T-piece is one mode, CPAP is another mode of spontaneous breathing trial. These are modes that you can try to assess if the patient is ready to be weaned or to be extubated. So if there's two choices, then the answer is probably the patient's not ready to be extubated. Switch the patient to SIMV. That used to be a like intermediate mode that we used to do. Um, it's not used so much anymore. So before people would do mechanical ventilation, you'd be put on like CMV or AC, and then the weaning mode would be CPAP. But SIMV is kind of an intermediate mode between the two. However, they found that instead of transitioning from AC and CMV to SIMV to CPAP, this whole transition would take a lot of time and the patient would tire out, and it wouldn't really lead to good outcomes with extubation. They found that skipping straight from CMV to AC to CPAP was better. So B is definitely the wrong answer, and A and C are the same direction. So the answer here would be to maintain the current ventilator settings, I think. Yeah. All right. So yeah, I can just reevaluate later. But if you were thinking about extubation, you can try one of these two, A and C, and then B, you just shouldn't do anymore. So emergency department, motor vehicle accident. Yeah, so probably could be trauma to the diaphragm, maybe flail chest. That's what you're thinking. But patient is hyperventilating and appears to have flailed chest. So if you're hyperventilating, you're going to be blowing off all your CO2, going to be anxious, probably have shallow breathing. So ABG results, your CO2 is going to be low because you're blowing it off, so your pH will increase. This will be a respiratory alkalosis. And it'll be an acute thing too, so there won't be adequate compensation. So your HCO3 will still likely be normal. Your SaO2 will probably be low because you have flailed chest. You're not able to adequately perfuse, ventilate one side. So increased pH, but what about the SA2? So it should be decreased because you expect them to have hypoxemia. In this case, this is a respiratory alkalosis. All right. So now mechanical ventilation assist control mode. They're not telling you if it's volume or pressure. She is struggling to initiate inspiration. So if she can't breathe, usually if you're in assist control mode, that means that it's similar to CMV. They're not actually always the same. So assist control means that the machine is giving its mandatory breaths. However, unlike in CMV, in assist control, if the patient initiates a spontaneous breath, then they'll get a full tidal volume too. So in this case, it's saying that this patient is in assist control mode. That means the ventilator is giving mandatory breaths. However, the patient looks like they're making spontaneous breaths, but the machine is not initiating it. So this is a problem of the machine not sensing that the patient is taking a breath. So changing the tidal volume won't change the fact that when they're doing spontaneous breaths, the machine doesn't notice it. However, it will improve or increase the volume of the mandatory breaths. The pressure limit has nothing to do with this. Pressure, the PEEP has nothing to do. So in this question is basically saying the ventilator can't sense that the patient is trying to take the patient's making his own breaths. And as a result, the assist control mode is working more like a CMV mode, but you wanted assist control. So you would improve the sensitivity of it. Yeah, um so basically what this machine, the ventilator is sensing is negative pressure because the ventilator breathes out um it's it's basically positive pressure ventilation that we're getting. Like the machine is pushing air into the individual to cause them to breathe. However, normal breathing is with negative pressure ventilation. So we usually breathe in, and this has more to do with more long respiratory mechanics. Like we usually expand our cavity and we have negative pressure pulling a lot of air in. And that's what the machine senses when it's in assist control mode. It will sense the negative pressure. It will sense that there's a increased, there's a negative pressure inside of the lungs, more so than usual, and then it will initiate a breath as an assisted breath, a spontaneous breath as well. However, when the machine's not able to sense that the patient is doing negative inspiration, then it won't deliver a breath. So nasopharyngeal airway in. So you put in a nasopharyngeal airway into the nose. Why do you do that? Well, it helps with suctioning. You can put a suction down. Um, it doesn't really help with ventilation. And in fact, you really shouldn't be having a nasopharyngeal airway when they have a mechanical ventilator in. So I think this has to do with frequent suctioning because then you don't have to reinsert a suction into the nose. Every time you need to suction, you can just insert it through the airway. There will already be a patent airway for you to go into. So patients need to have intact gag reflex. Yeah. So difficult to establish patent airway in a patient with which condition? Obviously, if they're fat. These things are like more properties of the lungs. So, not lungs are down here. When you intubate, it's up here. So if you're fat, it's up here. So, yeah. So infant positive pressure ventilation. Infants, why would they be on ventilator? Maybe ARDS, neonatal respiratory distress syndrome. Asymmetrical chest movement. That sounds like flail chest or diaphragmatic hernia. Hypotension. That's not good. They're already intubated. Asymmetrical chest rise. Maybe you can get a chest x-ray to see what's happening. Heel stick is kind of like the ABGs for infants. So if there's two choices that are ABGs, A and C, it's probably not the right answer. So it's just between B and D. All right. So transillumination can see if there's air inside the lungs. I feel like chest x-ray should be good just to figure out the cause. Or if you think it's pneumothorax, which it does kind of sound like they're getting positive pressure ventilation. So in ARDS, usually everything is symmetrical, but then they may have caused a problem with positive pressure ventilation. They may have like the lungs may still be very weak, and then they may have popped a hole in it. Yeah, so maybe just this is faster while you're waiting for the chest x-ray. Yeah, all right. Mechanical ventilation, simultaneous sounding of both high pressure and low volume. So we don't know what mode they were on, if they were on pressure or volume control, but you know it's high pressure alarm and low volume. So that sounds like you're not controlling either the pressure or the volume. But high pressure, let's just run through that. Could be a resistance problem or a compliance problem. And then if the pressure is high and if there's too much resistance, you might not get good volumes. And low volume, maybe something's leaking, right? So, but high pressure, I think the first thing you think of is resistance. There's probably not enough, there's probably so much resistance that they're not getting good volume. What is the most likely cause? There's a disconnection in the ventilator circuit. Well, you would have low volumes for sure, but pressure, probably not. Leak too. So disconnection and leak, I think, are very similar. So the volume's getting lost somewhere, but you shouldn't have problems with pressure. Mucus plug, yeah. Pneumonia, you would have high pressures too, but the volumes would be fine. So I think it's C. All right. They came into the ED for body development. What does that mean? Are they fat? They skinny? Oh, okay. Digital clubbing. So clubbing differential, it's not always in COPD, cystic fibrosis. There's certain cancers like I think adenocarcinomas, but this 16-year-old doesn't seem like he has cancer. Hyperresonance to percussion, productive cough, so maybe still COPD, cystic fibrosis. Hyperresonance pneumothorax? Probably not. The patient has been having foul smelling stools, so that's cystic fibrosis because in cystic fibrosis, there's a defect in the CFTR genes, and that affects your sodium chloride pumps. And then the sodium chloride transporters are in the lungs, the pancreas, and it also affects, yeah, the pancreas too. So you don't have enough enzymes and you cause these foul it affects the pancreatic digestive enzymes. So yeah, cystic fibrosis, foul smelling stools, digital clubbing, which is an indicator of chronic hypoxemia. So next one, 56-year-old female, distension of jugular veins. That's called JVD. JVD, we usually see that in states of volume overload. So perhaps this is a CHF problem, maybe a cirrhosis problem, maybe ESRD, a kidney problem. So it's definitely not B. Hypovolemia is off. Systolic hypertension, maybe obstruction of pulmonary vein. Could be backflow from the pulmonary vein to the right ventricle, to the right atrium, to the SVC, the jugular vein. Could also be right ventricular failure as well. So I'm between C and D, probably. So RV is more common for sure. And for PE, this could be a pulmonary embolism, but RV is more likely. JVD means like the jugular vein sticking out of the neck. Can be seen with obstructive disease too. Yeah, not entirely sure why it's not also C. All right, adult patient performed an FVC maneuver, low volume trace, and doctor describes the appearance of the loop as tall and skinny. So tall and skinny. So basically in your loop, you have inspiration, expiration, inspiration, expiration. So if it's tall and skinny, that means there's a problem with, that means you're expiring a lot. And then I think this is a restrictive disease because in restrictive disease, you actually have more elasticity. So your compliance is actually decreased too. So like it takes very low amounts of pressure to completely change the volume. So your lungs actually like flap a lot. So your I to E time is drastically decreased. Like normal's like 1 to 3. It might take you 1 second of inspiration and then 3 seconds to exhale it all out. But in restrictive lung disease, you just blow it out real quick. And that's the reason why you have decreased vital capacity because you keep blowing everything out. Yep. 68-year-old male, COPD, volume control, SIMV, volume control. There's probably going to be a problem with the pressures in this case. Something. So you start thinking about, is this a compliance or resistance problem? So the ventilator settings, respiratory rate 12, tidal volume. So I call this 12, 4, 80. They didn't tell us the FiO2, and then 5 is kind of the PEEP. So now they're doing a spontaneous breathing trial. Breathing rate increased drastically. What would you recommend? So it looks like we're doing SIMV, which is like this weaning mode, but they're still breathing quite quickly. You can increase sedation, but it looks like we want to wean him. Like we wouldn't just increase sedation for the next SBT. Could you do CPAP with pressure support? Yeah, it looks like so like T-tube, you're just breathing against this closed tube without any support. So you're not actually breathing against, you're not getting any support to breathe against the resistance of the tube. So we can give some pressure support. If you give pressure support without, if you don't give pressure support, you're basically doing a T-piece. And because they increased in respiration rate, you're not very comfortable with extubating. So that's why you would pick C. As I mentioned, it's because C, they would fail again, just like they failed the T tube. They're not getting any support to overcome the tube and then extubate. They're not ready to extubate yet because they failed the SBT. Increasing sedation doesn't make sense because you want them to be, that's one of the extubation criteria, that they're alert and able to protect their airway and that you've solved their main problem. So I think it's CPAP with pressure support. All right, good. All right, order to collect blood sample from neonatal patient in the NICU. It is determined you should obtain sample from capillary instead of arteries. So capillary blood gas is just like the ABG for infants. What is true about it? Um, so just like a venous blood gas, because like if you think about it, it really is a spectrum. Like there's an arteries, capillaries, venules, arterial. So like capillaries have arterioles and venules, and then you go to the veins. So basically, it's testing you that arterioles and vein, like if it's not arterial blood, what can you trust? And the difference between ABG and VBG, it's gonna be your oxygen. So your CO2 is going to be decent, your pH is going to be decent, but it's going to be underestimated. It's like the pH, it's going to be more acidic in the VBG compared to the ABG. So in the in the VBG, you're going to have lower pH, it's going to be more acidic and higher amounts of CO2. Um, that's just kind of the spectrum you go from arteries to arterioles to the venules to the veins. So here, the pH and PCO2 are still going to be decent. This is the same concept between an ABG and a VBG as as compared. So basically, if you were to draw out the circuitry, arterioles, arterioles, venules, veins, you would go ABG, then capillary blood, then VBG. And pH, PCO2 are going to be decent on all those. It's just the O2 that are going to be different because the O2 are going to be exchanged during the capillaries quite efficiently, just because of the large surface area of the capillaries. New patient admitted, pneumonia desats to 87. Oh no, let's give some oxygen. What's the potential cause? So pneumonia is a dead space physiology, or it's a shunt. It causes consolidation. Consolidation means that your the blood flow is going to be there, but it won't be able to perfuse because of all this inflammation. So, oh here, pneumonia is a consolidation issue. So, um, it's also a shunting too because you have blood flow there. but it's not getting perfused well. So consolidation. Yeah. 59-year-old female post-op patient. So post-op patients can get atelectasis. What you want to do is you give incentive spirometry as much as you can. This just kind of like opens up the airway. You want them to move around, ambulate too. It's one of the causes for post-op fever. There's this mnemonic called wind, water, walking, wound, wonder drugs. So if you were to have a fever post-op, within the first 24 hours, you're thinking some kind of pneumonia. Within the first 1 to 3 days, you're thinking some kind of maybe deep venous thrombosis after the procedure because they've been having a major surgery, they've been immobile, they're gonna be at risk for getting a DVT, PE. If it's like 3 to 5 days, maybe a UTI too. Um, Wind, water, walking, wound can be causing it, and then wonder drugs. Maybe they got a sacral ulcer. Maybe they're on some of the drugs that cause their fever. So drugs can happen and cause the fever in the beginning too, just because they're getting a lot of sucks, muscarinics, depolarizing blockers that can cause neuromalignant syndrome, hyperthermic, um, malignant hyperthermia too. So that can cause fever in the first day. So it's drugs. Wonder drugs is like for it's wonder drugs when water, walking, wound, and drugs at the end too. So drugs happen at the beginning, can cause fever in the beginning of the time course, but also at the end. So 63-year-old male, tracheostomy, mechanically ventilated, coughs, blood, secretions. So maybe pulmonary edema, maybe pneumonia, blood secretions blown back. It could just be from trauma from the tracheostomy. Um, so if there's a problem with the blood in the circuit, just replace the circuit. Makes sense. Guillain-Barré syndrome. So within Guillain-Barré syndrome, you see the decreased ascending paralysis, decreased reflexes. You want to get their NIF value, negative inspiratory force, because this is a problem, neuromuscular problem. So they're gonna have trouble breathing, just like obesity, hypoventilation syndrome. They're gonna have problems with their muscles. It's gonna be a kind of a restrictive pattern. So you want to make sure that they're getting adequate in because they won't be able to open up the muscles on their own. They won't be able to open up their lungs. The chest lung compliance system, their chest is like failing them. They really only have lungs. So, all right, 28. 64-year-old female, CHF, ED, 4 liters, nasal cannula. Fine, CHF. Give Lasix. What more is there to say? Coughing up large amounts of pink frothy secretions. Pulmonary edema from CHF. Give Lasix. ABG 7.42, PCO2 32. So like PCO2 is kind of low. HCO3 is low. So it looks like a respiratory alkalosis with metabolic acidosis. Looks compensated well. So SaO2 is low. PaO2 is low. We want to give them some kind of oxygen. CPAP does help. Intermittent positive pressure breathing helps as well. So CPAP is good for CHF. Intermittent positive pressure breathing is good too. Not sure the difference between the two. It was CPAP, pretty sure. All right, that sucks. All right, wean adult patient from mechanical ventilation, switch them from AC mode to CPAP. So it sounds like they're trying to wean them, but then the high respiratory rate sounds. That's not good. They're breathing fast now. So, but they're being weaned, so they probably had a little bit of stress from being switched from AC mode to CPAP mode. So I think 30 to 35 is generally tolerable. So this is not a failed extubation. We'll just continue to monitor if it goes way higher, like, because you can go like 10, up 10. So like 22 breaths is considered like 12 to 22 is normal. So you can tolerate even up to like 32. So I would increase the high rate alarm up. Then if the patient still can't do it, um, then it'd be considered a failed extubation. Yeah. Emphysema, emphysema. Maybe this is COPD. The PCO2 is 65, but it looks like it's well compensated. Yeah, it looks like well compensated. The pH is normal. So maybe COPD retaining, but well compensated dyspneic inspiratory crackles. Crackles. They could use some BiPAP. Nasal cannula is not going to cut it. PaO2 is terrible. It's 47. Non-rebreather versus albuterol could help, but it's not really wheezing. Lasix probably will help in this case. Air entrainment is good. So it shows that they have compensated respiratory acidosis. PO2 is low. It's lower than what you would expect in COPD. We want above 55. SpO2 greater than 88. They don't give us the SpO2. Yeah. So you just want to help them provide FiO2, nasal cannula, non-rebreather, air entrainment. This is like the Venturi mask. Yeah. ED, orally intubated with endotracheal tube. Orally intubated with an endotracheal tube. So what do you do initially to confirm that the tube is in the right position? Oh, so intubated, make sure tube is in the right place. You listen first, then you get X-ray. Then you also like usually estimate, um, you can estimate how far to go in, like usually 21 to like 25 lip line is good. You want it to go like 2 to 4 centimeters above the carinum. You want it like between the second and fourth intercostal spaces. So you can do landmarks, you can listen. So you can listen. You wouldn't be able to tell if it's only in the right brainstem bronchus if you did capnography. Yeah, you listen first. Apgar, it's 10. Apgar, this is a mnemonic for the score. Each point it's graded from 0 to 2. Yeah, there's 5 items in the score, so it's 10 in total. Confirm tube is in place. Breath sounds absent on the left side. Oh no, you put it on the wrong side. You intubated the right main stem bronchus, just move it back so that it's back up 2 to 4 centimeters above the carina. So emergency department, extremely deep and fast breathing rate. So that's tachypnea. That's not a choice. So apneustic means you're not breathing at all. It's like apnea. And then Kind-Stokes is more for stroke and trauma. Never heard of this. So don't pick stuff you never heard of. Um, and then Kussmaul breathing is like see it in DKA. They're breathing really fast, and that's because they're in acidosis and they're trying to blow off all the CO2. Nice. All right. 71-year-old male, ventilatory support, secretions yellow and thicker. So secretions, cystic fibrosis, he seems too old for that. COPD, perhaps, does he smoke? Um, and then secretions, maybe pneumonia, maybe sinusitis. White cell count 17,000. Now we're thinking more than infectious cause, maybe more pneumonia, temperature, fever. So this is a um, pneumonia. Sepsis secondary to pneumonia. We have a clear source. Let's get sputum culture and sensitivity. Suctioning is great. However, we don't know if they're breathing poorly. Like if definitely we should suction them if they're desatting, but probably not twice every hour. Bronchodilator. Let's treat the pneumonia first. Nice. FEV1 FVC ratio severely decreased. What would you expect? So FEV1, FVC less than 70%. This is an obstructive problem. Severely decrease. So there's this mnemonic I like to use for obstructive problems. It's usually cystic fibrosis, bronchiectasis, emphysema, aspergillus, and then chronic bronchitis too. So emphysema and bronchitis make up COPD. Cystic fibrosis, bronchiectasis goes along with bronchiectasis and aspergillosis. So asthma is also an obstructive too. It goes along with COPD. Nice. 37. Intubated patient SBT. So what are criteria for things that can stop failed extubation? People have all these different criteria, but if you just boil it down to, look, patient is in distress, let's stop this SBT. Why are they in distress? We can think of increase in respiratory rate, generally more than 10 to 12 above normal. If their heart rate just like shoots up to like greater than like 120s and they sustain there, if if they desat for sure, right? Like if they drop like 10%, that's a failed if they're hypoxic. If they look are using respiratory accessory muscles, that's horrible. And then if if they start retaining too, that could be bad too. So here, increase in heart rate, nothing to write home about. 96 to 114, whatever. Respiratory rate 17 to 27. That's still okay. Because like upper limit of normal is 22, so we can tolerate probably up to like 32. Um, it's below 30 for sure. Yeah. PCO2 increased. That could be concerning. SpO2 dropped, is below 88%. That's not good. They need to be back on it, but why not? Why not C? That's a question. Yeah, it's probably not too large, you know. The pH is probably within normal. 44 is normal, and then if it just goes up from normal to 52, your bicarb can support that. You don't need to be on a ventilator, but perhaps you would probably extubate to BiPAP. Um, yeah, there's a non-invasive way that you can do it. Nice. Dynamic compliance. Compliance is volume over pressure. So divide the volume by what? Tidal volume by what? So you want your peak pressure divided by the peak pressure. So it's just your driving pressure. It's like the difference between the highest pressure and the lowest pressure. So your peak pressure is your PIP and then your PEEP. That's going to give you your driving pressure. Because the driving pressure is basically the differential you're getting every time. PEEP is going to be a flat baseline rate you're getting in peak pressure. That's going to be what's going to change. You get a puff, then it goes down. You get a puff, it goes down. So I think it's this. Nice. 63. ICU. Bronchial breath sounds over the right lower lobe. So bronchial breath sounds you mostly have within the upper airway. If you're starting to hear it over the lower, that's not good. Uh, Usually means you have some kind of pneumonia. So it's not normal. Pneumothorax, you would hear like decreased breath sounds because you would have an air interface and you wouldn't hear it. Pleural effusions, decreased breath sounds. Consolidation. Yep. Bronchial breath sounds. Good. Alert 59-year-old male orally intubated. Great. Switch to CPAP mode. Great. Looks like we're doing SBT. Respiratory rate increased. Oh no. Usage of accessory muscle. Oh no. Looks like a failed SBT. So definitely don't extubate. CPAP mode. Oh, it's still okay. So return the patient to full ventilatory support. Perhaps they failed SBT, increase FiO2. It's not going to do anything. So, yeah, it'd be nice to know what the CPAP mode was. They failed SBT. Looks like CPAP mode, just FiO2. I think I think this question is just poorly written because CPAP mode usually you give some pressure, but it looks like they just did CPAP mode without they just did CPAP mode without giving you pressures. So CPAP mode, you have inspiratory pressure as well as expiratory pressure. You have your pressure support too. So 5 to 10 pressure support generally means that you're giving a setting of, let's say, baseline PEEP of 5 pressure support, so 10-5. Um, a lot of people like to do a PEEP of 5 and give a pressure support of 7, like a and expiratory pressure of 5 and a pressure support of 7. Some people like to give a expiratory pressure of 3 and pressure support of like 9 or 6. So I think what they're saying is you did CPAP only FiO2, but you really should be adding um, pressure support, or you just return the patient back to ventilatory support. But you first have to really try to give some pressure support. Before you stop the trial, You need to give pressure support. 5 to 10 is a good. To going back to that question, you calculate how much pressure you need to overcome the resistance of the endotracheal tube. So the resistance is Poiseuille's law. So resistance is like the viscosity coefficient times the length divided by the radius to the fourth power. So albuterol, what side effects? Tachycardia, shaking tremors. So not bradycardia, but shaking tremors, not hypotension. All right, nice. 23-year-old male, severe head cold, oxygen via nasal cannula 4 liters, SpO2 85, looks like the patient desatted and has a cold. So it's probably congestion. That means that the nasal cannula is not being able to penetrate into the nose. They probably have some like mucus, stuffy nose. So what we would give is we can try a mask. Or we could increase the oxygen flow. We wouldn't decrease it. Yeah, mask better. Stable adult patient, mechanical ventilation. Looks like they're alkalotic. PCO2 is low. Maybe they were blowing too quickly. The settings on the ventilator are like the respiratory rate, tidal volume, FiO2, the PEEP. So it's like if I were to say like 12, 4, 50, 50, and 5, that means the respiratory rate is 12. The tidal volume is 450. The FiO2 is 50, and then the PEEP is 5. So the things here that are leading to a decreased CO2 in this patient, normal CO2 is 40. It's going to be increased respiratory rate or increased tidal volume. So to decrease it, we would decrease the tidal volume. 68-year-old female in the ICU getting mechanical ventilation, but asynchronously breathing with the ventilator. What you can do is go up on the sedation. So if you wanted to go up on the sedation, you could increase your propofol, increase your Precedex, give something like a paralytic. You can give something to help sedate them, like Ativan. You can give Precedex is dexmedetomidine, not dextroamphetamine. So you would give a sedation here. Nimbex you can give, but really it's controversial, and you don't want to paralyze anyone unless they're adequately sedated. Paralyzing them without making them sedated can make them just be fully conscious but paralyzed. It's one of the worst feelings in the world. 70-year-old male with COPD receiving ventilatory support in a volume control mode. High pressure alarm suddenly begins to sound. What do you do? High pressure alarm, volume control mode. Um, you assess pressures. So high pressure alarm can be from a resistance problem or a compliance problem. If it's resistance problem first, we should suction first, then compliance problem, making sure that there's no like abdominal compartment syndrome, ARDS, pneumonia. You can culture, get chest x-ray to see what's happening if you really don't know what's happening. But suctioning will reduce the resistance that you get from the mucus. Nice. 55-year-old female, pneumonia, oxygen. How do you evaluate patient's ability to breathe? Pulse ox, chest x-ray, ABG. Ability to breathe. Well, that's if you want to know how their brain's gonna drive them to breathe, then you need to know the CO2 and the pH. If you want to know just So yeah, so CO2 I think drives the breathing more than the oxygen. So all these are like oxygen based. This will just tell you how they're breathing now, not like the compensation that they're directed towards. So yeah. Blunting of the left costophrenic angle is that like fluid pleural fusion, history of CHF. So it's on the left side. So it's pleural fusion. Nice. SBT from mechanical ventilation. So SBT, of course, we don't want a desaturation. SpO2 drop is not very acceptable. Which one would be acceptable though? So A, no. Increased usage of accessory muscles, scaling muscle, no. Increased heart rate, yeah, that's fine. It's less than 120. Systolic blood pressure drop, no. Yeah, so it's kind of like what we were saying before. If your SpO2 is dropping below 88, that's not good. You want it below 50. The PaO2 for COP is like 55 that you want. And then the other cutoff's like 70 mmHg. That's when you're like hypoxic too. You don't want your pH to drop too much. You don't want it to drop less than below 7.3. You don't want the PCO2 to increase too much. You don't want heart rate to be more than 120s, 140s, because then that might be like you're not giving your heart enough time to fill and perfuse the rest of the body well. So you'll have more of a cardiogenic cause of not perfusing the rest of the body. 49. Fluid overload given furosemide. Good idea. Displayed arrhythmia. Maybe you over diuresed them, so they're going into arrhythmia. Maybe you got rid of all their potassium. So what I would do is check the patient's potassium level. But also if you check their potassium level and it's abnormal, so yeah, hypokalemia can cause arrhythmias. However, if you've given the repleted potassium or the potassium is normal and they're still in arrhythmias, it could be from hypovolemia too. Sometimes we overdiurese patients and they're very sick. So they have CHF, you overdiurese them, but since they're still sick, if they go into low volume or low potassium, they're very, very sensitive to arrhythmias. Make sure their magnesium's good too. So some people like to do for every liter of Lasix that you remove, and this is a lot, like you're getting rid of so much fluid. You want to make sure that you're giving magnesium as well. So that could be a good thing. Like if they go into arrhythmias, start them on magnesium. Um, it'll help give them some fluid as well as replete their um, magnesium and also improve the potassium. Generally, when you replete one cation, it helps the other cations. For magnesium and potassium, the explanation is because there's ROM-K channels that when you replete the magnesium, it activates those ROM-K channels so that you get more potassium back in the system. So it's able to absorb more of the potassium that you're giving the patient. If you have low potassium, even giving sodium can improve the potassium. The reason for that is that you have these sodium potassium exchangers. So if they have low potassium and you give sodium, then the sodium is less incentivized to leave the cell via the Na plus K plus. So if the sodium's not leaving the cell, it'll go into the cell and potassium can come out of the cell. So you'll improve their hypokalemia that way. So generally, as a general rule, giving cations will improve cations. After the extubation of a 54-year-old male, sore throat. What does that mean? It could be laryngeal edema. Perhaps you didn't do the cuff lead properly. When you have the endotracheal tube in and you have a cuff, over time you can start to have like some laryngeal edema, swelling. The cuff may not deflate properly. When you deflate the cuff, you really want to hear a whoosh of air, like a sound of cough. If there's laryngeal edema, what you should do, um, if you hear this stridor, they didn't say stridor, but if you hear like sore throat, maybe laryngeal edema, racemic epinephrine is the way to go. Nice. Oropharyngeal airway. So that's good. You shouldn't use the oropharyngeal or nasopharyngeal airway when people are intubated, but also it's for people who are unconscious. So if they have a gag reflex, you shouldn't be using this. Just take it out if you hear a gag. 66 ED, shortness of breath, chest tightness. Is this pleuritic chest pain? Is this heart attack? Is this um just non-specific, but you still want to make sure it's not heart attack and individual at um 66. So cardiac enzymes, they're fine. Results negative. ABG, respiratory acidosis. So BNP is normal. It's not heart attack. It's probably not CHF. Because BNP is normal, they don't look like they have signs of fluid overload, no edema, compensated respiratory acidosis. So that means they are not breathing well. Maybe this is COPD. This sounds like COPD. It's not pneumonia. You wouldn't be compensated. It wouldn't be a chronic problem. Nice. 51-year-old male, volume control, AC, mechanical ventilation, has pulse ox. Remove from the ventilator and drops. So when you're suctioning and if you suction and then you remove them from the ventilator and the desat, like surprise Pikachu face, like of course they're gonna desat when you remove them from the ventilator. So the answer is not to remove them from the ventilator when you're suctioning. So you want to close suctioning, inline suction. Chronic asthma. So their slow vital capacity is 3,500. Forced vital capacity is 2,500. That just means there's a large difference. Like vital capacity is um, basically the living capacity. So it's just not the residual volume. So it's just like taking a deep breath in and then a deep breath in, so your vital capacity as well as your expiratory capacity. So if there's a difference, that means that uh, you're able to breathe more out when it's slow. Um, and when it's just your regular vital capacity, you're not able to breathe out as much. So this is an obstructive pattern. It means that you're able to breathe out more when you give it more time. You need a higher I to E time or a lower I to E time. You need for each second of inspiration, you need like 5 seconds or 3 to 5, more than 3 seconds to expire out all the air. Because these capacities are usually measured at 1 second. So if there's a difference between the 1 second time and the 3 second time, that means you need more time to expire. Difference is because of differences in exhalation. There might be an obstructive pattern. There could be air trapping, so you don't expire out everything because of the elasticity is collapsing the lungs. All right, nice. 55. Ordered acetylcysteine, large amount of secretions. That's great, but they don't cough. So acetylcysteine breaks up the secretions. However, you need a cough reflex. Recommend. So instead of getting rid of the secretions, probably just suction them. Yeah, just suction them. So patient got inhaled corticosteroids via meter dose inhaler, 2 puffs daily. Okay, steroids can cause thrush. You rinse your mouth after inhalation. You gargle. with mouthwash so that you have decreased rates of infection from thrush because steroids like immunosuppress you. They stop the inflammation from the area, so a fungal infection can just sneak on in. So that's why you just gargle some stuff, some salt, destroy the fungus. So assist control mechanical ventilation. Which of the following is the most common problem? So in assist control, the unlike CMV, in assist control, you're getting your breaths in, boom, 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 but you're also getting spontaneous breaths too, but at a set tidal volume. So you breathe, the machine's pushing 500 milliliters, 500 milliliters, but then you take breath, then you get another 500. So you can sneak in a lot of full breaths for this. So you can have hyperventilation because you're sneaking all this full breaths in. You're gonna be blowing a lot of CO2. Need for neuromuscular paralysis. Yeah, well, you breathe fine. You breathe, you can have your own spontaneous breaths. The ventilator does work with you. It allows you to initiate spontaneous breaths. But the problem really is the fact that when you breathe, you get a full tidal volume in addition to the full breaths that are already set on the ventilator. So if you set the ventilator too high, you set it at like 22 rate per minute, and they're still breathing over the vent, that means they'll get their 22 breaths, but then whenever they breathe on top of that, they're gonna get a full tidal volume, not just like mini volumes that you would get from rapid shallow breathing or Kussmaul breathing, because the machine is forcing the full ventilation, the full tidal volume. So the instant they develop any tachypnea from like pain, anxiety, or acute distress, they're getting full tidal volumes. Their CO2 is gonna fall like crazy. They're gonna go alkalotic. Yeah, nice. 77 kgs, tidal volumes 550. That kind of seems high, but it's okay. The peak pressure is 35, less than 40. I'm happy with that. High pressure limit is 64. Seems kind of high. Low pressure alarm, 25. Maybe you could decrease that. Low tidal volume alarm, 500. The ventilator is we don't know if it's pressure controlled or volume controlled. So we don't know what we're watching for. But pressure alarms, if this is aired, yes, you probably want less than 40. I would probably decrease the high pressure alarm. Low pressure alarm, whatever. It would help us if we knew if this was volume control or pressure control. Or PRVC, increase the low tidal volume alarm to 600. Yeah, I'm just gonna go with my gut because when you're doing lung protective ventilation, you want the ARDSNet trial looked at people and they broke them into two different groups, like a lung protective strategy and those that didn't get lung protective strategy. And lung protective strategy had two components. A lot of times we just focus on the low tidal volume ventilation. We try to keep them between 4 to 6 mLs per kilogram of their ideal body weight. However, there was a component of it that was also low, it's protective pressures too. So you want your peak less than 40, plateau less than 30. So peak really should be less than 40 here. We shouldn't be keeping it up at 64. The volumes are fine. If this was pressure control and you were adjusting for the volumes, then maybe you would want to focus on those alarms. Nice. Admitted to the ER ABG. So asthma attack means you breathe fast, pH goes up, PCO2 goes down, and there really shouldn't be PaO2 problems, maybe. It's less than 70, but for COPD, you want greater than 55, but this patient has asthma, respiratory alkalosis with hypoxemia. The only one is these two. But you should be breathing it out. So it's not, so pH alkalosis is these two. PCO2 should be low because you're breathing it out. So it should be this one. And you should have hypoxemia. Nice. All right, last question for now. So FEV1, FVC lower than predicted, making obstructive pattern. FEV1's usually less than 70%. The ratio is less than 70. FVC is lower than normal. But FVC is more of the lung capacity. In obstructive disease, your FVC should be very, very high because you're obstructed. You can't breathe out, so your vital capacity, which is how much is retained, is your vital capacity is how much is in the lungs. It includes your end residual volume, expiratory residual volume. So you should have increased residual volumes in obstructive disease. So there's two things happening. The FEV1, FVC is lower, obstructive, FVC is lower when it should be high. So there's a restrictive pattern that's forcing the air out. So not only can you not get air out, you can't keep it in. Normally with obstructive patterns, you can't get air out, so it gets stuck in. So it's kind of like you try to blow out, you can't, so you keep expanding. In restrictive pattern, you can blow everything out really quickly, so your FVC is low. So when you have a patient that not only can you not blow out, but you can't keep anything in, so you just nothing goes out, nothing comes in. You have both combined obstructive and restrictive pattern. All right, nice.